I want to go ahead and thank everyone for joining us this evening for our October seminar for MCHSA. We have a very interesting seminar this month. So I'm going to go ahead and introduce our speaker. Dr. Miles is an associate professor of pediatrics at the University of Alabama, Birmingham School of Medicine. She's also the director of the UAB Leadership Education in Pediatric Nutrition Program, which is a training grant funded by the Maternal and Child Health Bureau to train professionals and students in pediatric nutrition and MCH. Dr. Miles has been a dietitian for over 30 years and has practiced in multiple settings as a clinician and an educator of undergraduate, graduate, and postgraduate students. Dr. Miles has focused her practice on pediatric nutrition, primarily on child and adolescent obesity, feeding disorders in children with special needs, and eating disorders in children in adolescence. So this presentation is based on her years of experience with youth and eating and weight-related problems. So I want to thank her for being here today and give her a warm welcome.
So it's great to have you here, and I am so happy to see some familiar names in the audience. So we're going to go on a little road, on a little trip. We're going to take a stroll down a path, and what you can expect to hear about today is, first, I'm going to tell you a little bit as to why I wanted to speak on this topic, about weighty issues in prevention of weight-related problems in youth. I'm going to talk a little bit about prevalency of these disorders or weight-related problems, why adolescents are at greater risk, and then end hopefully with what we can do as individuals, as public health professionals, and as healthcare professionals. So as Nita said, I've worked as a dietitian for over 30 years. I have devoted my career to pediatric nutrition. It's been my love, and I also have had the opportunity to work at universities training future dietitians or young dietitians. So that's my other love. But I've been very focused. So it's almost like I have blinders on. So when I get into an area, I focus very deeply in that area, and I learn everything that I can about that area. And through most of my career in pediatrics, I've done a lot of work with children and teenagers with overweight, obesity, and also work with children with special needs, particularly those with eating issues. And when I just joined UAB actually about a year ago, exactly a year ago. And I remember thinking about coming to UAB and going through the interview, and I knew that they had a large eating disorders program. And I remember thinking, well, I have never done eating disorders, and I don't even know that I will like it, but I like other things about the job. So, why not? Little did I know that I was going to be deep into the world of eating disorders within a few months. And little did I know that I really, really liked it and enjoyed it. But I started seeing how my job included working with trainees at our clinics. And we see both ends of the weight spectrum. We see youth with overweight and obesity, and we also see youth with severe malnutrition. So we go from very malnourished to significant obesity. And I started feeling like there was this dichotomy in my work. On the one hand, I'm trying to get people to eat. On the other hand, I'm trying to get people to change their eating habits. And I started reflecting or wondering if what I was doing was helpful. And more than anything, I started wondering, am I doing the right thing for those individuals with overweight and obesity, or is anything that I'm doing perhaps exacerbating the problem of disordered eating. So I started, with my focused lens, I started looking into the literature about feeding or not feeding, weight-related issues in youth, and this presentation is a result of that. But really, my inspiration is the individuals that we see in our clinic, and I wanted you to see the growth chart of just one of our patients, and it's just one of many. But I wanted to showcase this young lady because of a few things. One is she is Latina. Her parents are from Mexico. She was born in Mexico. They immigrated to the United States. This young lady is bilingual, but her parents only speak Spanish. So we need an interpreter when they come to clinic. The other characteristic is that they are from a lower socioeconomic status. They have Medicaid as their insurance. They live far away from Birmingham, so they have quite a drive. They don't live in a big city. And in many ways, I feel that, many years ago, we used to think that eating disorders was something that white, rich girls had. And this is just the antithesis of, what a white, rich girl might be. So, lessons that I've been learning, it affects everybody. It has no qualms, it's all races, ethnicities, socioeconomic status, sexual orientation. So this young lady, on the right, you can see how she was growing. The bottom left, on the left, the bottom chart is her weight for age, and you can see that she was at the top of the weight for age chart in earlier childhood, up to around age 10. And you can see her height also was, probably, not as high as the height. And you can see the BMI was between the 95th and 97th percentile. So we would classify this young lady at this earlier age as having obesity. But let me tell you about her story. Around 8 years old, she started being bothered by being teased in school about her weight. So she started feeling poorly about herself. She didn't like it. She didn't like her weight. She didn't like her size. She was unhappy. So she had body dissatisfaction. But you can see that things actually took a turn for the worse when she was 10 years old. And starting at 10 years old, we see a dramatic decrease in her BMI. When we saw her first in our services, she was 12 years old. So what happened? So remember, she was already dissatisfied with her weight and her size and her shape. And then at age 10, her mother was diagnosed with breast cancer. So we can see that might have caused some type of anxiety within the household. But on top of that, a year later, her dad got diagnosed with stomach cancer. And this young lady is super smart, very high achiever, very good student. And of course, she went to the internet to figure out, how to prevent cancer. Now she has a mother with breast cancer and a father with stomach cancer. And of course, nutrition, you eat healthy. So long story short, by the time that she came to the emergency room at age 12, she had lost a significant amount of weight. She was barely eating some fruits and vegetables, exercising 2 hours a day, and she was very malnourished. And to go from this, state of having obesity and feeling very dissatisfied with oneself to having significant, severe malnutrition, yes, it took a couple of years. And you would think, well, get some therapy and then go back to normal. And you can see that we've been struggling. She's been struggling with us for a few years, and we are not making great strides. It's a constant battle. We see her every 2 weeks. Also dramatic if you see her height. So she stopped growing taller. She can't gain, she's not gaining enough, so she's not growing taller. Originally, I also wanted to talk about health disparities in weight-related problems with children, and I'm not going to have time to delve into that, but I would say she's an example of what we experience in health disparities. We see this in overweight and obesity, the lack of sufficient primary, secondary, and tertiary care for childhood obesity. And we see the same thing in eating disorders, where this young lady that has Medicaid, a family that lives in more of a rural area, parents that don't speak the language, there's been countless challenges with getting her counseling, and even more challenges in the possibility of her going to a residential care. So this is my inspiration, and these growth charts, these dramatic decrease or shifts in BMI, where my inspiration for my search in trying to figure out, is what I am doing with our young people. Am I helping, or is anything that I'm doing hurting? And what does the literature say about that? And what has research told us about that? So let's start with statistics, because we're health professionals and we like to know, what the prevalence of different disorders are. So it's no secret that overweight and obesity in the United States is high. Roughly, we could say that about 1 out of 5 children has obesity in the United States. And then the rates are higher among our racial ethnic minorities. In youth, Hispanic leads the way, followed by Black children. And then we see some, prevalence in white, down to about 16%, and lower in our Asian populations. And of course, COVID blessed us with a pandemic with many repercussions, but also greatly increased the problem of overweight and obesity. So we went from about a 19% prevalence of overweight obesity in the United States in youth to 22%. And what the numbers are showing us is that children who already had overweight or obesity gained weight at an even faster rate than children with no overweight and obesity pre-pandemic. So definitely some, additional negative consequences in this aspect for our youth with COVID. And then, so I'm talking about the both extremes, overweight, obesity, and malnutrition. And then eating disorders, we don't have very good surveillance for eating disorders. So it's very difficult to get great numbers of prevalence. We feel, or we know, that there's about 30 million people in the United States that have an eating disorder. So this graph here, I looked up what the population of the United States is, and this is 30 million people right here in the orange. And what impacts me the most, because of the population that I work with, is that the majority of people with an eating disorder are between the ages of 12 and 25. So, we just talked about our youth having overweight, obesity, and now, so many of our youth being the majority of those affected by eating disorders. And as I said earlier, it affects people from all walks of life, all socioeconomic status, all races, all ethnicities. Approximately 4% of teenagers between the ages of 13 and 18 have anorexia, bulimia, or binge eating disorder. So it's a pretty good number of our youth. And of course, it also affected, the pandemic also affected the number of youth that developed an eating disorder during the pandemic, or their issues were exacerbated by the pandemic. And I came during the pandemic to UAB, and at one point I did the calculations. I got data from our clinic about referrals to our eating disorders clinic pre-pandemic, and then post-pandemic, or during the pandemic, really last year, and it was a four times increase in referrals. So it quadrupled the number of referrals, and that's just our clinic. So ER visits greatly increased the number of inpatients. So it really did a number on our youth in terms of weight-related problems. And why? Well, there was so much. There were so many messages during the pandemic, and I remember during COVID, I think I probably did laugh when I would see something like this on social media. But now I think, I wish this type of funny meme was not shared, because adolescents were on their phone or on their laptop all the time, and they were not on a screen doing homework necessarily all the time. That was their only connection. So they were exposed to all these, all this fear of gaining weight and having to flatten another curve. And gaining a lot of weight, and sometimes that alone, causes more disordered eating and more dissatisfaction with one's weight. There are a lot of studies that look at what our youth, how are our youth, our children feeling about their bodies, and I just picked 3, but it's appalling. It's appalling to know that as early as age 5, there was one study that looked at 5-year-olds, and 34% were already reporting moderate to severe dietary restraints. So they were already watching their weight. They were already watching what they were eating because they were concerned about their weight. And these are 5-year-olds. So if you're going to have trick-or-treaters for Halloween, look at those little kids and look at the 5-year-olds and think, why would a 5-year-old be worried about their shape and worried about dieting? 50% of 6 to 12-year-olds are dissatisfied with their bodies. So half of the youth in this particular study were dissatisfied. Youth should not be worrying about their body shape or size, but they are. And 29% of 10 to 14-year-olds have already tried to lose weight. So again, it's very sobering to think that youth is feeling so poorly about their own weight. What's worse, and this is actually research from the University of Minnesota, Dr. Newer Steiner has led Project EAT for decades now. And it's the longest study of middle schoolers and high schoolers. So she started, or her team, because she has an amazing research team, started looking into the behaviors of middle schoolers and high schoolers in the Minneapolis-St. Paul area, and has followed them for years. So they are now adults having children that have children. But what was really interesting about a lot of the literature that they have published as a result of Project EAT is that youth with obesity, so the middle schoolers and teenagers that they were looking at, those who had overweight and obesity reported higher levels of disordered eating than youth without obesity. So pointing to the fact that children who have overweight and obesity are at risk of developing really unhealthy behaviors. And thus my desire to really find out, what messages should we be giving these children so that we don't go from one problem, quote unquote, having obesity, and in our desire to help them be healthy, actually have them start another problem, which is disordered eating or an eating disorder. That's another agonizing problem. Also, her research shows how boys are also suffered from disordered eating or eating disorders and behaviors to try to lose weight, like smoking or fasting or taking diet pills, etc. So certainly the University of Minnesota has done tremendous work in this area of, how these eating behaviors develop and how disordered eating develops, and also, what are protective factors in terms of disordered eating. So if you're interested in this topic, Dr. Newmark Steiner, Project Eats has a website, and if you look her up on PubMed, you'll find hundreds and hundreds of papers by her team. Okay, so but why are youth, at greater risk of having developing some type of disordered eating behavior? Well, of course, adolescents, their body is changing. If you remember when you were going through that transition, it's pretty shocking. Girls also, they will gain a little bit of weight before their height takes off. So many times I can't even tell you how many mothers have said, oh my goodness, I'm so worried, such and such developed a tummy, and I'm worried that she's gonna get fat, and it's like, it's something that happens. They gain a little weight, they develop a tummy right before they shoot up. And we do our youth a disservice by not telling them, you're about to grow really, really fast. And that means you're going to get taller and your weight is going to go up. That's just part of growing up, and your shape is going to change. But what happens is that some adolescents get overly worried and develop this body dissatisfaction and preoccupation with their weight, which is very easy for them to engage in disordered eating behaviors because they want to lose weight. And then once those get entrenched, their mental health takes a dive, and once an eating disorder starts, it's very difficult for them to go back to their happier selves when they didn't think about food all the time and worry about every bite that they were taking. Also, adolescents, they think they're adults and they think they know everything, but their brain is still developing. And something interesting about the adolescent brain development is that not all areas of the brain develop at the exact same time. So parts of the brain develop before others, and the part of the brain, the prefrontal cortex, which is more of the part of the brain that will make rational decisions, that is one of the last portions of the brain that will develop. The limbic portion of the brain, including the amygdala, that develops sooner, and that is the more emotional, reactive portion of the brain. So if we wonder, why do adolescents behave in this manner sometimes, it's because their brain is not fully developed, and it's a lot easier for them to engage in risky behaviors and think that taking diet pills is okay, or laxatives are not going to hurt me, or purging is just something that I do once. They're not thinking as rationally as an adult would be. This is from the same paper, and I just found this fascinating. It was a simulation, and they put individuals in a little car, and first they have to try to get as far as possible on a road, knowing that at some point light is going to turn red and they need to stop, and if they don't stop, they're going to hit a wall. But the thing is that they all want to think that if they go really, really fast, they're going to go longer. So they're trying to go longer than other people. And you can see that adolescents, when they're alone, they might have some restraint, and when they're with peers, it's like they always hit that wall. It's like they never want to break, so they see the red light and they still want to keep going, and they hit that wall. 24-year-olds, they don't take that many risks. It's not worth it. I don't have to win this game. And then 18 to 22-year-olds are in between. So all this to say, our youth, our adolescents are at such great risk of engaging in risky eating-related behaviors because of many things. They're changing a lot, but also it's a lot easier for them to not see the danger in engaging in certain behaviors. And certainly they never imagine that once they start going down a certain path, they're not going to be able to stop. So what can we do? So first, I wanna start with, we currently, for the most part, have a dichotomy when we're talking about messages for our youth. When we're thinking about obesity prevention, we focus a lot on healthy eating and physical activity, and those are marvelous things that help everybody. We all know that obesity is not as simple as eating healthy, or people saying eat better and exercise more, because such a large portion of our population doesn't have access to healthy foods. They live in food deserts. They cannot afford healthier foods. They don't have a safe place to be active. There's no sidewalks, there's no parks. They don't have access to good medical care. So, yes, everybody should be eating healthy and exercising, but we know that childhood obesity is not as simple as this. There's many, many factors why we have so many children are suffering from overweight and obesity. So we have these messages for overweight, obesity, and then for eating disorders preventions, the programs that have been run usually focus on promoting body satisfaction, avoiding diet, talking about diets and any weight-related talk. But there's almost like this dichotomy between either I'm preventing obesity or I'm preventing eating disorders, but not a mesh between both messages. But back to what can we do as health and public health professionals? So one thing that the literature shows is that there are some common risk factors for youth that predispose them towards weight-related problems, being overweight, obesity, or disordered eating disorders. So individuals that are already dieting and engaging in unhealthy behaviors, definitely at high risk of developing more of a disordered eating disorder. Individuals with low self-esteem, so many times, that is a trigger. People comment about their weight, or they already feel bad about their weight, and that gets them down the wrong path. High body dissatisfaction. Media, what children are looking at, what youth is looking at, what we are looking at. Traumatic life events certainly are another risk factor. Social isolation. So now we know why the pandemic really exacerbated problems for our youth with both obesity and eating disorders. Also, children and youth with mental health problems. We see a lot of anxiety, mood disorders, depression. The family and the peers also have a lot of influence. So, or the family structure and the peer structure. Family meals are protective. That's a lot of this work also has been done at the University of Minnesota. Family meals, children and families that eat as a family more often have better nutrition, less overweight and obesity, less weight-related disorders. And for the parents to be able to model good eating behaviors is also important. But if they're modeling dieting behaviors, that definitely would be a risk factor for our youth, which leads me to, those of you in public health. we have such a long way to go in really making sure that we're teaching parents how to feed children from birth through adolescence. Parents don't know how to do this, so we need to help them figure out what parenting tools and techniques and modalities they can use. So it's beyond what they feed them as far as food, is how they feed them as well. I can't, I'm always surprised, but I don't know why, as to how many of our youth that were criticized by family members end up, with an eating disorder down the road. It's not everybody. Obviously, there are a lot of risk factors. Teasing, bullying, social pressure, parental demands, and also parental anxiety, substance abuse, families that are separated, etc. Those are also risk factors that we see in the literature that, are risk factors for children in developing a weight-related disorder. And finally, youth, social, the school and community. Coaches and teachers have such a strong influence on our youth. And there's been so much information in the media and in social media, at least I seem to see it all the time, about coaches really trying to get kids to lose weight because they're going to run faster, or they're going to be better at their sport, etc. And it is such a disservice towards our youth. And then teachers, the attitudes of the teachers, if teachers are perhaps overly concerned about their own weight. I remember doing a class for the family and consumer science teachers at my daughter's high school. And I don't even remember what I was going to talk about, but it was during their lunch hour. And before I started, they're all opening their lunch and everybody's looking at what everybody else is eating. And then they start talking about what diet they're on and how they need to lose weight. And I thought, oh no, these are the facts, teachers. And I hope they don't talk this way in front of the teenagers. Because they hear all these messages. What the food availability. So the community has a lot to do with being a positive or a negative risk factor, cultural norms, weight discrimination, and certainly media messages. And I would say that the environment in the United States is pretty toxic. I would say that we are starting to make some strides in being more inclusive of, in commercials, for instance, having people from different races and ethnicities being portrayed. I actually think this started with the murder of George Floyd during the pandemic. So there was more of a cry for diversity. And we're starting to see some more people that have different shapes also portrayed, but we're a long way from really being an inclusive society. So the first thing then, what can we do? The first thing was no risk factors. So when I'm working with a young person and I'm seeing that teenager with pre-diabetes, I want to know, are there any risk factors here that, is there anything that I'm going to say to this young lady with pre-diabetes that has obesity that may actually make her feel worse, bad about herself, and push her towards, any disordered eating behavior that ends up being worse, much worse, than having obesity per se. So the second thing, though, is check your unconscious bias. And I am a firm believer in all of us making sure that we know what our implicit biases are. This also became very popular with the murder of George Floyd. But I am proud to say that I was already basically making all my students take an implicit bias or implicit association test beforehand, because I had to do this during my doctoral degree, and it was eye-opening to me. I always thought, well, I'm Latina, so of course I have no biases. And then I did the implicit association test, and I'm like, oh, gee, wow. I do have biases that I didn't know anything about. And for my students that are going into nutrition and dietetics, I want them to definitely, I typically say you have to do 3 or 5. And there's a variety of tests. There's race, ethnicity, religion, political affiliation. But the one that they always have to do is body size. Because I want them to know if they have a preference for a smaller body size, and if that is a bias, because I never want them to be working with somebody that's living in a larger body and reflect that bias to our youth. The third thing, that we can do as public health and health professionals is watch our language. Now, this slide only has from the American Academy, I think it was from pediatric obesity. They did a survey of youth with overweight obesity and asked them what terminology they liked. And they definitely did not like to be called fat, large, obese, or extremely obese. They preferred weight problem, BMI, or plus size. So being sensitive about, the words that we're using in individual interactions, but also when we are coming up with programming, or when we're coming up with any educational material for our youth. I work with amazing individuals, and one of our physicians and we were doing a session with a group of high school students last spring. And it was a group of teenage girls, and the topic was self-image. So they wanted to talk about self-image, and they were just really candid about, some of them feeling really insecure about their body size, and feeling like they were overweight and not feeling good about themselves. And there was this young lady there who certainly was, was a larger size young lady, but she's like, I don't know why you worry about that. It's like your weight is your weight. You have value no matter what. So the physician that I was working with goes, okay, so let me ask you something, because I'm always cautious about the language that I use. So what would you like, somebody to call you or describe you, because people don't like sometimes BMI or overweight or obesity. And she goes, you can call me Fluffy. So Fluffy was, she was a fluffy girl. But it was good in that, it was so exciting to see her have such a good self-image and be encouraging other young ladies to feel good about themselves, because weight is only a number. Yes, we want our youth to be healthy. Yes, we want to encourage healthy habits, but no, we do not want them to have a poor self-image and feel like they have to take desperate measures to achieve a size that is typically not realistic. And then be cognizant about those messages that we're putting out. I have been involved in many programs for children with overweight and obesity, and I have to say that only a few really focus on the self-image of the child. So this is from the literature as well, also from Dr. Newmark-Steiner. So messages that address both the obesity, the children that may have obesity, and the eating disorder prevention. So we're trying to get our kids to be, our youth to be healthy. And what are messages that encourage, healthy eating and healthy lifestyles without, pushing kids towards, disordered eating. So eating regular meals and snacks and avoiding erratic eating, evidence-based, this is good for everybody, no matter what your body size is. I see it all the time in clinic with youth. Teenagers seem to love to skip meals. And then we see the overeating, because they get so hungry and just grabbing whatever is in sight, and then that definitely creates very poor eating habits. Paying attention to hunger and satiety cues, that's something that we should be teaching our kids from the very beginning and encouraging our adolescents to listen to hunger and satiety cues. Now, of course, if you're working with somebody that already has an eating disorder that's a restrictive eating disorder like anorexia, they stopped listening to hunger a long time ago, and they will not get hungry. So if you tell them, oh, wait to eat until you're hungry, they're not gonna eat. Eventually they'll regain that. But for the most part, just for prevention of problems with eating, teaching our kids that we eat when we're hungry, we stop eating when we're comfortably satisfied. It works for everybody. Enjoying physical activity and movement. There's a lot of dietitians that I know who do not like to talk about exercise or even use the word physical activity. They talk about movement, because many times people engage in physical activity because they want to control their weight. So physical activity or movement or exercise should not be a means to keep your weight stable. It should be something to be healthy, get your heart healthy, to enjoy, moving or being outdoors. But it's not a means to an end of, controlling the weight. Valuing the body. So again, programming, that we might put together to teach health to our youth needs to include something on their self-image and how to value their body, and give some anticipatory guidance that they're going to grow really fast. And yes, there's going to be weight gain. Of course, you grow taller, but you also gain weight. And sometimes, the weight precedes the height increase that happens in girls. And learning to manage stress. And I am very lucky to work in a department that is, it really encourages us to manage our stress. And with people that are doing some research currently with youth on mindfulness. But if there's another lesson we gain from the pandemic, is that our youth does not know how to manage stress. And when they saw themselves, between, four walls and a screen, their mental health suffered tremendously. So really incorporating this into our programming. And then this is from the American Academy of Pediatrics recommendations for obesity and eating disorders in teenagers. So, the same types of messages, avoiding calorie restriction to promote weight loss and dieting. With the adolescents that I work with who have obesity and may have a comorbidity like prediabetes or hypertension, I am not giving them a 1,000 calorie diet. When somebody is forced to go hungry, instead of really embracing that diet and feeling good about what they're doing, they're going to hate it, and then they tend to overeat later because they cannot keep that low calorie level. So we're just promoting shifts. We're gonna make shifts. You're eating this. What about this? And making small changes. Family meals, again, the research does show that children and youth that eat more family meals tend to have better diets, better nutrition. For parents and teachers and coaches, refrain from talking about weight, and that's so ingrained in our society. Inquiring about weight teasing and bullying. So many of the youth that we work with will tell us that, yes, the kids at school are teasing and bullying. And certainly, there's a lot of work to be done in schools to prevent that from happening, because words are so hurtful. And then lastly, promoting that healthy body image that as I've mentioned before, I've been involved in several programs for youth with overweight and obesity, but we emphasize so much the eating and the physical activity, but truly we need to also worry about their own mental health and their own self-image, and to encourage them to like themselves and value themselves. Weight is just a number, and there's so much more than they can be proud of. So with that, I am going to end and stop sharing my slides and see if there are any questions.
I do apologize. My dog is barking in the background, but I do have a question. You kind of touched on it at the very end, but this is like such a multifaceted topic that you're covering. I was wondering, so when you meet with a client, like possibly the one that you mentioned in the beginning, how much of it is focused on your mental health, and how much of it is focused on changing nutrition? Are they kind of tied in, if that makes sense?
Yeah, it does make sense. So I would say I'm always cautious about their mental health. So we typically have a chart, we have some history, and we ask some questions. I am not a mental health provider, so I'm not going to delve into therapy with them, but I'm very cautious with during the interview, they will typically say something about, how things are going in school. So we ask some background questions. Where do you go to school? What grade are you in? How is school going? And typically something comes up that might be a little bit of a red flag, that there's some bullying, or they feel poorly about themselves. And, the strategy that we use is motivational interviewing. And it is really coming up with getting the client or the person to come up with some small changes that they can make. But you're talking about the patient that I talked about at the very beginning. So I was thinking you were talking about overweight, obesity. So our role as a dietitian within our eating disorders program is to help these individuals come up with eating goals. So we're always trying to get them. So somebody that has anorexia and is restricting their eating, we're always asking them to go up and up and up on their eating. All our patients are encouraged to have a counselor, and we try to make sure that they get mental health. They need that more on a weekly basis, sometimes bi-weekly. But I personally, as a dietitian, I'm not delving into their mental health issues. My intent as a dietitian is to make sure that we're getting more nutrition. So part of that is a lot of education. And I have to say, I say the same thing every single time. You need carbohydrates because your body needs glucose, because your brain needs glucose. You cannot just eat protein, and there's a role for fat. Let me tell you what fat does, cell structures, et cetera, et cetera, et cetera. So I really do focus on that aspect, which is the nutrition. They're also seeing a physician, and then they have, we want all our patients with an eating disorder to have a mental health provider that sees them more often. I don't know if that answered your question.
Yes, it did. Thank you so much.
Mm-hmm.
Hi, Dr. Miles. It's good to see you again. I did have a question for you. So in the beginning, you were talking about some of the statistics around the eating disorders. I'm curious as to, I guess, some of the racial, ethnic differences that you have noticed around the eating disorders. I'm sure there's so many different things we can kind of look into with that. But this has been such a great presentation. Just wondering if you had anything there.
Thank you. So we see every race, every ethnicity, we see boys, and we see a very significant number of transgender youth, and youth that have body, dysmorphia, youth that are, transgender. They tend to suffer. They're at greater risk of disordered eating for various reasons. So if it's a young lady that or somebody that's biologically a young lady that feels like they're a male and want to transition to a male, when they start developing curves and breasts and a period, that is just frightening to them. So one way of trying to stop that is to not eat, so that those curves go away and the period goes away. But we see Black people, Black individuals, males and females. We see quite a bit of Hispanic, Latino. I can't say that I have seen a lot of other ethnicities or races, but we're in Birmingham, so I would say that would be the majority, and certainly white. But every socioeconomic status, every walk of life, people that come from really tiny places in rural Alabama, so this is not a disease that it only affects certain people. It affects everybody. And so, Neildra, I don't know, it's great to see you, by the way. This young lady gave me a tour of UT Knoxville a few years ago, and I think I walked 14,000 steps with her. So it's good to see you. And I don't know if I answered your question.
Yes, thank you. I appreciate it.
Sure.
We have probably time for one more question.
I have one question.
Yes.
Hi, Dr. Miles. I think I joined UT around the time you were leaving, but it was great.
I know who you are,
today.
sweetie. I know who
Yes.
you are. Hi, Candace.
Oh, awesome. This was a great conversation. And I was wondering, what can we do as researchers and, dietitians to better identify, especially young people of color who have disordered eating or eating disorders? I know, like, when I practiced as a dietitian, it felt like my Black and brown patients had so many health and, like, social concerns that sometimes it felt like eating disorders, they were important, but like, I had like a patient who maybe was experiencing domestic or family violence, or, a new, like, acute diagnosis or something, that it almost seemed like so often eating disorders got pushed to the back, or even they went undiagnosed because we were looking at things that, were so visible. So I don't know if you have any like recommendations, like, I don't know, research or practice or both.
Yeah, I think that's a really good point. I think that some of our minority populations have so many stressors already that we tend to not think about an eating disorder because there's just so much going on. There's so many things that are that are impacting that family negatively. I would say adding there's some disordered eating screeners that can be easily added. There's some that are only a few questions that can be easily added if you're doing research in a certain area. I certainly encourage you to do more research on our minority populations, which, Candace, I know that would be of course for you, but to add some questions about disordered eating to your screeners. We tend to think that doesn't happen as often as it does, but it really does. And many times the eating, it's more embarrassing to youth to admit to their disordered eating or eating disorder, it's easier to say, I don't know, I'm engaging in other risky behaviors or I'm failing school, but the eating seems like a shameful thing many times, and other behaviors are, less shameful. Or they feel like, that's happening to me, but surely that it can't be that bad. It's only eating, or it's only laxatives, or it's only vomiting. So, asking, having those screeners as part of, your research, or screeners as part of the questionnaires that perhaps a client would answer when they come see you as a dietitian.
Thank you. That's really useful. I'm gonna make sure I have some screeners in my intervention.
Okay, good.
We've come to the end of the seminar. I want to thank you again, Dr. Miles, for speaking with us today. It's a wonderful presentation, and thank you everyone for being here. And I hope you guys all stay safe and have a wonderful evening.